was really interesting for me to review this topic. So for the last 10 years or so, research in my laboratory has been focused on non-alcoholic fatty liver disease. And I'm going to start by giving you an overview of this. And I'd like to talk to you both about the genetic risk factors as well as dietary. So I should clarify that I am a nutritional scientist. My first degree was in human nutrition, and I've been studying nutrition for quite a long time. So the middle of the talk will focus on nutrition and lifestyle in both prevention and the treatment of non-alcoholic fatty liver disease. And I'm going to end by talking about sugar. This has been a very hot topic for the last several years. I think there's a lot of confusion. I suspect this is a really educated audience, so forgive me if I repeat things that you know, but it seems that there is a lot out there in the media that's not entirely accurate. So very simplistically, non-alcoholic fatty liver disease is defined as more than 5% lipid accumulation or fat accumulation in the liver, and it's in the absence of other diseases. And there's a bunch of things that will cause fat to accumulate in the liver, including alcohol, some of our drugs, anti-cancer drugs. So the first thing that your health professional needs to do is eliminate those other potential causes. So it's an umbrella term that is defined histologically. So when you look at a liver slice under the microscope, non-alcoholic fatty liver is often referred to as simple steatosis, and steatosis is the accumulation of fat in the liver. When the disease progresses, you get the onslaught of inflammation, and this is referred to as non-alcoholic steatohepatitis, which is lipid plus inflammation. And this comes plus or minus fibrosis, and as the disease progresses, you get more and more fibrosis. Cirrhosis is the end stage, and at this stage, the cirrhosis doesn't look any different from alcoholic cirrhosis and is the risk. One of the big issues with this disease is that it's fairly challenging to diagnose. So it's generally found incidental, which means that somebody walks into their GP's office and they're getting a full blood panel and maybe they have elevated liver enzymes, or maybe they're complaining of a little bit of pain and the GP is thinking gallstones and they do an ultrasound. The issue with liver enzymes is that in 79% of people with fatty liver, your liver enzymes are completely normal. So other tools, the other way that can be used is through imaging. So this is ultrasound or transmission elastography, colloquially known as FibroScan, which is an instrument, computed tomography or magnetic resonance spectroscopy. There's issues with all of this. So ultrasound will only pick up fat in the liver once it's gotten to 30%. Not every GP's office is going to have a FibroScan. And of course, you need to be close to a research hospital to be able to get into an MRS. There's a bunch of scores and algorithms which are being used to triage people because we don't have a blood test for fatty liver disease. And I've highlighted the ones that the NICE guidelines here in the UK have decided upon. Fatty liver index is made up of height and weight and a couple of other factors. And the ELF, which is a test that includes some markers of fibrosis. But biopsy is the gold standard for staging the disease accurately, so establishing where along the pathogenesis pathway that you are. There we go. So thank you to Dr. Keneally for setting this up really nicely. Non-alcoholic fatty liver disease is tied very closely to obesity. And a huge study that was published recently that's looked at NAFLD all around the world has sort of estimated that about 80% of people who have the steatohepatitis are going to be obese, and about 50% of simple steatosis is associated with diabetes. Type 2 diabetes and metabolic syndrome are also comorbidities that you typically see. And for this reason, although clinical guidelines, and these have been published by the Americans, by the Europeans, and in the UK, they all conclude that we shouldn't be generally screening people in the population. However, NAFLD should be suspected in anybody who has type 2 diabetes or metabolic syndrome. So it took a long time for us to figure out that the liver was getting fat alongside the rest of us. And this is most recent data which shows the prevalence worldwide. And the circles refer to the prevalence of a genetic risk factor that I'm going to talk about a little bit later. Quite surprisingly, it's found very high in Asia and also very high in the US. And here in Europe, we're kind of racing to catch up with this sort of incidence. So the big challenge, I suppose, in terms of non-alcoholic fatty liver disease is there is no drug for it. So just like we don't have a really good test for it, we also don't have a really good drug for it. And currently there's a lot of things in phase 2 and phase 3 clinical trials. I wouldn't be betting on any of them myself. This is a long list. And also some dietary factors have also been looked at. So what that leaves us with as a nutritional scientist is nutrition. Now, one of the interesting things about this disease is because of the diagnostic challenges, our understanding of the natural history, and by which I mean how it develops and how it progresses, has been evolving. Because if you're relying on people to take repeat biopsies with those big long needles, you might get them spaced apart, you might miss phases of the disease, it's not really clear. So we used to think the disease was quite linear, where a normal liver progressed to steatosis, which then progressed to inflammation, and then it went to fibrosis, and then it went to cancer or to end-stage liver disease. Now, this screen, unfortunately, doesn't really project this very well, but there's some big question marks here. So one question that we've been asking based on the different incidences of NASH. So 25% of the population have fatty liver, but thankfully only a smaller percentage, although this is increasing, have the inflammatory disease. So one question the hepatologists are asking is whether or not this is a unique group of people. The arrows that you can't quite see that is quite worrying is whether or not you can develop hepatocellular carcinoma, so develop cancer in the absence of having gone through all of the steps. Factors that are associated from a nutrition point of view with disease progression include right at the top weight gain and inactivity, saturated fat. There's been lots of talk about fructose, which is why I'll talk about sugar a little bit later. Vitamin D deficiency, choline deficiency, all associated with progression of the disease. Fortunately, there's good news, which is that nutrition can also be associated with regression of the disease. And I've put another question mark here, which is really interesting. So the reason, fit clinical trials are really good for us is because one of the things, the fascinating thing that's come out of the clinical trials that have been done to date is we're actually seeing, potentially seeing regression from fibrosis backwards. Now, this could be because somebody missed the disease on the first biopsy or on the second biopsy. There are issues with it, so it remains a question mark. But we are seeing placebo-treated individuals have regressive disease. So this remains an open question. So associated with regression is weight loss, again, right at the top. Mediterranean or low refined carbohydrates. I echo Dr. Keneally in saying, let's not get crazy about low carbohydrates. Let's be very specific about what types of carbohydrates that we're speaking about. Vitamin E supplementation has been used in children to treat the disease. Omega-3 supplementation, omega-3 fatty acid supplementation as well. Less data on polyphenols, but it seems quite probable that they play a role. So this is sort of an overview of the pathogenesis, and I'll go quite slowly through this. So let's start at the top with the diet. Sugars in the body are converted to fatty acids via de novo lipogenesis. Of course, the other source of fatty acids in the liver is fat from the diet. But by far and large, the most fat that's coming into your liver at any one time comes from adipose tissue. So these are non-esterified fatty acids, which normally we want coming from our adipose if we're fasting. Unfortunately, nowadays, nobody really ever fasts. So if you follow here fatty acids, normally these are built up into lipid intermediates. They're brought into triacyl glyceride, which I abbreviate as TAG, and then they're formed into these very low density lipoprotein particles which go into circulation. And this is good, right? This is how we get the fat out of our diet, through our liver, into where it's supposed to go. But what has become apparent over the last several years is this process, this flux. If there's an excess of fat in the liver, then you end up with this leading to inflammation. So inflammation is driven both by the gut. I won't give a lecture today on the gut microbiome, but it's certainly linked with non-alcoholic fatty liver disease as well. And also what we've learned a lot about in the last decade or so is that adipose tissue, once it's in excess, can come in two flavors. There's nice, safe subcutaneous fat, and then there's what I refer to as angry adipose tissue, secreting adipokines, which also drive inflammation here in the liver. And that is mediated, fibrosis is mediated in part through hepatic stellate cells, and Kupffer cells are the resident macrophages. So where does genetics play into it? And this is kind of a brief overview. And what I have listed on the slide here are the genetic risk factors for which there have been multiple studies, so not just one-hit wonders. But apart from their long, scary names, what I want to focus on is this idea of risk and risk variance. So if we're looking at the factors that determine how much triglyceride you have in the blood, there are lots and lots and lots and lots of genes that contribute to this. But generally, fewer variants tend to have a larger effect size. PNPLA3 was the first that was identified, and that was only as recent as 2009. This particular gene was identified last year in March by Regeneron's scientists and is actually protective if you have the loss of function variant. But because I'm a nutritional scientist, one more slide, just to bring the genetic risk factors back to pathogenesis. You can look at a variety of different stages in the disease at the molecular level. What fascinates me is the number of genetic risk factors that are involved. The top four are all involved in the process of moving lipids through the liver. So PNPLA3 is found associated with these lipid droplets. TMP6S7 mediates VLDL secretion. But having focused on those, there are also factors related to inflammation and oxidative stress, lipotoxicity, and factors that are involved in terms of driving fibrosis. So now I'm going to bring it back to nutrition and talk about gene and environment interactions. So Sue mentioned phenotype, so this is how much of what you look like to some degree, but also in terms of how the disease presents itself. So we have genetic risk factors that drive fibrosis. These in general have a high effect size. And I should have said to you, what's interesting about the genetic risk variants is that they mediate risk for a variety of liver diseases. So they're not specific to NAFLD. So we're, having a polygenic risk score doesn't entirely work in terms of specificity. So we've got risk variants associated with fibrosis, risk variants associated with inflammation, and then a lot more that drive fat accumulation. So there's lots of genes that influence whether or not you carry weight on your hips or around your stomach. But one thing is for sure, that all of the risk is driven in large part by diet, adiposity, and insulin resistance. I just wanted to mention one of the risk variants because I think it's a great example of gene environment. Again, this is very recent, so the two alleles here were identified only in 2014. And if you have one of the variants, one of the alleles, you end up with decreased VLDL secretion from the liver. And you end up with a much higher risk of fatty liver disease if you eat too much, or you can get fatty liver disease from consuming too much alcohol as well. On the other hand, if you have the C allele, you end up with increased VLDL excretion, and you end up with much higher risk of cardiovascular disease. So you might say, oh, Bernadette, that's damned if you do or damned if you don't, but it goes back to environment, right? You're not going to get either cardiovascular disease or fatty liver disease if you maintain your body weight. So a very critical role for nutrition, which leads me to the fact that nutrition is modifiable. And I'm going to pose to you the dietary nutrients may differentially affect either the development or the progression of the disease. Weight loss is really fundamental here. So when we talk about diets and do they work and everything else, the main driver is, of course, either weight gain or weight loss. So how I probably got roped into this is Dr. Keneally and I worked together, and this is a summary of a review that Sue led, looking at diet and physical activity interventions. Since we've published a few, other people have as well, so the findings all hold up. And the way we separated these trials was we looked at trials that either examined weight loss alone, or examined exercise alone, or examined a combination. And as Sue said, when you start looking at trials, they're all heterogeneous, but we can take some summary points. The first one is that the combination trials are by far and large most effective. And patients at the moment, and this is again sort of the consensus in the field around the world, is they should be advised to lose 5 to 10% of their body weight. If they're already at the stage of NASH, you need to err on the higher rather than lower side. And so we give sort of standard recommendations, which is to consume a mildly hypocaloric diet and to engage in regular exercise. Now again, being very kind, you have to take your patients where they start out. So it could be in the beginning, you're just getting them to walk 5 or 10 minutes, but moving up from there. The dietary composition is less important than total energy intake. And low carbohydrate diets may be slightly more effective, but I warn you, they're only effective at 6 months. They're only more effective at 6 months. If you follow up patients that went on low carb versus low fat or whatever other diet, you follow them up at a year and the net weight loss is the same. Everybody kind of gains weight back in the second 6 months and ends up about, if they're lucky, 2 kilos down after a year. Aerobic and resistance exercise appear equally effective, but if you look at the exercise studies alone, they're going to be less effective than diet. And I want to mention food bioactives because I think it ties into where we're going here in terms of plant-based diets. The evidence base, right, there's no RCTs looking at any one of these things that will give you a satisfactory answer the way the medical paradigm would like for drugs. And of course, when we eat, we're getting a mixture of all of these things. But there's lots of in vitro and preclinical data that suggest a lot of these compounds will affect the stages of pathogenesis that I've spoken about. So, which leads me to the evidence for plant-based diets, and that was what I enjoyed reviewing for this talk. My summary to you is that currently there are no randomized controlled trials that have got liver endpoints. So that's why Sue has sort of briefed you on weight loss. The studies that exist, and there are 3 that I'm going to tell you about, slightly conflicting. They're limited. They're limited by the fact that 2 of them are retrospective, cross-sectional, and 1 is an observational case control. So this is limited again in that paradigm where you need a randomized control trial to prove that something works. So the first of these studies is the one that was negative. It's quite interesting, actually. I had no idea that Buddhist priests got fat, but they do. So this was a retrospective study of 615 Korean Buddhist priests, and they had age, sex, BMI, metabolic syndrome matched controls. Diagnosis was by ultrasound. And in fact, not only was there no difference between the Buddhist priests and the general population, this was not a significant difference, but there was it appears that there was a trend towards a higher incidence of non-alcoholic fatty liver disease in the priests. And they had higher ALT levels and AST levels, those are those liver enzymes, higher levels of TAG and higher levels of glucose. So that was the negative study. In terms of the observational case control study, this one was done in India, and here they took 464 consecutive NAFLD diagnosed patients, and they compared them to 181 consecutive folks who had walked in for an ultrasound but didn't have fatty liver. And what they found was that there was a lower prevalence associated with a vegetarian diet, but you notice this prevalence is not zero, right? It's 23%, so it's not completely saying this is the cure-all. The last study that I found was just published last year. This is the advantage of being large, so sort of 18,000 US adults. And in the US, they do a national health and nutrition survey that goes through several periods. It's been rolling on for several decades. And here, what they've done in these nutrition surveys, they take very detailed nutrition information, which is a positive, and they went through this long rigmarole to rate how much plant food people were consuming, and then they ranked them into tertiles. So they had 16 different food groups, and that include healthful plant foods, less healthful plant foods, as well as animal foods. And what they found was that a plant-based diet or a healthy plant-based diet was negatively associated with NAFLD incidence. On the other hand, the unhealthy plant-based diet was positively associated with liver disease markers. So I think echoing some of Ellen's points that you can eat a lot of junk food as a vegan should you so choose. The other thing that they showed was that the folks that were in the upper tertile of plant-based food consumption had 21% less risk for NAFLD than those who were in the lowest tertile. But again, not a zero risk. So I want to also mention the Mediterranean diets. This is a student of mine who's currently systematically reviewing it. And when we started, I didn't think that there was going to be enough for us to systematically review, but there have been some studies published. And this summer, actually, I hope to have a medical student repeating this. So I'd like to start by saying the European guidelines for fatty liver disease, when they were published, recommended, in addition to the 7 to 10% reduction in body weight, that macronutrient composition should be adjusted according to the Mediterranean diet. This raised some questions at the time, because at the time they based that recommendation on one study that had been done in 12 people. And there's a bunch of Italians on the board, so there's some risk of bias there. So again, I am a very conservative scientist, so I don't like to talk about things until they've been confirmed a few times. But if I was betting on what our results will be, I think we would probably say that adherence to a Mediterranean diet can help in terms of improving liver markers of NAFLD. And for sure, it's been investigated a whole lot more in terms of overweight and obesity. But there's always a but if Bernadette is talking. I worry about the Mediterranean diet, first of all, because I think you can achieve that macronutrient composition on a variety of different diets. So there's the Norway diet, there's plant-based diet. I think you can get to the Mediterranean diet without living in Italy or Spain. And one of the concerns that I have is if you go looking at it, you find that most of the studies have been published either in Spain or in Italy. And then there's financial considerations. So there was a very big study that's gotten a lot of press in terms of cardiovascular disease, and they basically gave everybody bottles of olive oil and nuts every single week. The Mediterranean diet can be quite expensive. And if you're giving people olive oil and nuts, well, they certainly know that what arm of the study that they're on. So I want to, having said that, I thought that I would highlight one particular study that was published last year and is absolutely fascinating. And it goes back to what Sue was talking about in terms of being kind. The reality is, and nobody likes it when nutritional scientists say this, but no matter what diet people try when they're just dieting, people tend to gain weight back. There's so much in our environment that is stacked against people, and once you have gained a lot of weight, it is very difficult to lose weight and keep it off. Your physiology is now stacked against you. And so because of this, people are sort of balking at the recommendation that people lose 7 to 10% and saying, well, is there anything else we can do? And it goes back to what are the properties in food that could be beneficial. So this study was published, and what it did was look at either a Mediterranean or a low-fat diet where the goal was not to have the patients lose weight. So ad libitum means by choice, people were eating what they chose. It's important to point out they didn't want them to lose weight, but they did anyway, and both arms lost weight. And you can see here, if you have quite astute eyes, that the Mediterranean diet came in a bit heavier. And this is heavy, right? So this is 89 kilos at a start, or 81 kilos, so 30.1 on a BMI, or 31.8. So definitely in the obese category. But the weight they lost, the amount of BMI that shifted, was very minimal, and certainly not at the 7 to 10% that you would expect. So that was the first surprise. The other aspect of this is that both arms lost weight, or lost liver fat, excuse me. So here's the data where they came in, and these patients went through an MRS, and there was 56 to begin with, and it dropped down to 49, so relatively small study, but quite expensive once you're putting them in a scanner. So both arms lost hepatic fat, however 20% liver fat is not zero. And the Mediterranean diet, what differentiated the two, and again, they were given olive oil and nuts, and the low-fat arm was given low-fat muesli and I think other low-fat snack products. So both arms were given food to minimize the cost. But fairly impressive, within 12 weeks, they saw the nutritionist for the first 4 weeks every week, and then they saw them 4 weeks later, and then at the end again. So I suppose a big question is, can they stick it out and get that liver fat back down to 5%? So that leads me to sugar, and I'm going to finish up here with sort of sugar 101. I'm going to start by reminding you that sucrose is a disaccharide. It's chemical made up of glucose and fructose. And when we talk about high fructose corn syrup, you're getting glucose and fructose at about 55 to 45%. When we talk about the difference between glucose and fructose and sucrose, you can see it illustrated here. Whether you buy a glucose syrup or a fructose syrup, essentially you have a more runny sugar. So fructose has gotten an awful lot of press since a particular paper was published in 2010. This was food frequency questionnaires were used for this, and they found that fructose consumption was associated with fibrosis and more severe disease. And it's been scrutinized because if you look at a graph that shows you how much obesity has increased, and you look at a graph that shows you how much high fructose corn syrup consumption has increased, they look very parallel. But arguably, since our Coca-Cola here in Europe is sweetened with sucrose instead of high fructose corn syrup, if high fructose corn syrup was the problem, we wouldn't have fatty liver disease. So that's one hole in the arguments. The other holes in the arguments is that the studies that have been done that have given interventions use much, much higher doses of fructose, usually a fructose solution that's giving you 20% of your daily calories from fructose alone. So that's not the way we consume fructose, even the teenagers who are drinking the most monster drinks. And when you look very carefully at the studies, the ones that have controlled for energy find no differences. Is there a debate? This is a review that I wrote with my lovely colleague, Barbara Fielding, and I'm going to give you just 3 messages. The first is that we're all consuming too much sugar, okay? Nobody gets out of this, right? So here's the percentage of energy that we're consuming as sugar. We do get better as we get older. We tend to consume less. Teenagers consume the most. And there is huge variance here, but the median is about 12 to 15% of the total energy per day from sugar. So if you're getting 20% from fructose, that's very different from how people consume it. But undoubtedly, there's no shadow of a doubt, everybody agrees from the WHO to the UK guidelines here, if you have free-living people who consume more sugar, they put on weight. If you ask free-living people just to reduce sugar, they will lose weight. So there's definitely a causal link between high sugar diet and obesity, and dental caries as well. So the WHO and the UK made their recommendations for us to consume less sugar based on the obesity data and based on teeth. Now, in teenagers and all children should not be drinking sugar-sweetened beverages at all. There's something about drinking sugar as opposed to eating sugar that really predisposes us to type 2 diabetes, and people are getting this at a younger and younger age. I'm going to argue that focusing on individual sugars, focusing on fructose versus just sugar, is not entirely, first of all, the mechanisms are dubious, but second of all, from a public health perspective, it doesn't really make a lot of sense. There are major challenges in our current environment for consumers that want to cut down. First thing is that there's over 60 different names for sugar, and really brown rice syrup. There are things, maltodextrin, that's in like almost every power bar that's out there, and you don't go, ooh, maltodextrin, that's sugar. Well, it is. And the other big challenge is that there's a real problem with the way we market natural and raw sugars. If fructose is the problem, agave, it's like 80% fructose. So if you are worried about fructose, don't be consuming agave. And I show this slide to my undergrads because I get really frustrated at some of the misunderstandings that are out there, but I just want to show you where sugar comes from, right? So this is the agave plant in Mexico. Here's sugar cane, which is grown in India and South America. Here in the UK and Europe, we grow these sugar beets. And let me show you where natural raw sugar comes from. So it gets crushed, it goes through the roller mills, goes through here, out comes syrup, out comes here, doop, doop, doop. And here's your raw sugar. In the EU, by labeling laws, when you buy light brown sugar or dark brown sugar, they've taken white sugar and they've put back molasses into it, 3% or 6% to get to light or dark sugar. But nonetheless, there's an awful lot of processing that happens before you get to your raw cane sugar. And this is a slide that I've picked up from Nub's Kitchen online because I think it speaks to things. So I once wrote a letter with Barbara Fielding to the Sunday Times because they had one of these sugar-free cakes, and it had maple syrup and it had chocolate in it, and it wasn't sugar-free. So sugar is not bad for you, right? If you brush your teeth and you're a normal body weight, eat your sugar and don't worry about it. But let's not be confused that one sugar is better or worse for us, than another. And I can't go into the sustainability questions, but this is a slide from Professor Tim Benton at the University of Leeds, who really focuses on this, and a real area of interest for me is sort of the political consequences of raising sugarcane and how the food system is. So anyway, here's sugar. We don't need it for a healthy diet, but look at what percentage of our production capacity goes to it. And there's the health halo effect. So did a small study where we surveyed people and asked them what their preferred sweetening ingredient is. Honey, coconut sugar, agave. Down here at the bottom is table sugar. And then you ask people why. It's supposed to be healthier. Healthier raw sounds so it's slightly healthier. It's natural, naturally occurring. It must be better for you. And the government has produced guidelines on reducing sugar for the prevention of childhood obesity. And we need to do this, right? So we have an awful lot of children starting school at age 5 who are already overweight or obese. And by the time they finish in year 6, we've got same levels of obesity as we do in adults, 25%, like age 11. It's just shocking. So the government produced these guidelines, and they've given like a 9 list of the top food products that contribute to sugar in a child's diet. And I looked at this list and I said, okay, well, sugar-sweetened beverages, no problem. Cakes, cookies, biscuits, no problem, I get that. And then there was yogurt. And you know, I am a molecular biologist by training. I'm not a dietitian. I'm not a clinician like you guys here. And I was like, how much sugar is in yogurt? So this is a picture of my daughter 10 years ago, 9 years ago, I suppose. And at that time, I was mushing up, you know, the vegetables and, you know, doing my best to kind of, you know, give my daughter the best start in life. But one of her favorite meals when she was learning to eat herself was sugar-sweetened yogurt. So anyway, I went and said to Barbara, I was like, let's look at yogurt. What's the story? And it led to this paper. And what was interesting about this paper, I had published a very dense systems biology paper in August, and I got about 10 geeks on Twitter looking at it. But this particular paper somehow went viral and is in like the top 1% of papers that have ever had media attention. And it was picked up by all our press, and it was picked up internationally in France and South America. I got really excited, having once lived in America, when the Good Morning America producers were on the phone to me. So what did we find? Why was it so interesting? So first of all, we were quite comprehensive. We looked at 920 products available in the top 5 supermarkets. And here's the 5% line, which is required for your back of the label that gives you a green traffic light. And here are the median sugar levels of children's yogurt. But the one that bugged me was organic. I'm sure everybody in this room knows that organic refers to production, but a lot of people think organic means healthier. Yeah, there's lots of sugar. And when you look at how much sugar a 4-year-old should be eating, and usually by age 4, you've moved them on to the same yogurt the rest of the family is having. One pot, this isn't 100 grams, so if you have a pot of 150 gram yogurt fruit on the bottom or something like that, you're getting most of your sugar in the day. So I'm just going to wrap up, having given you my little scare tactic on sugar, and talk about some evidence-based practice guidelines that I think are consensus-based. Lose weight, maintenance is critical. Exercise, start off slowly. So there was a study that I was just alerted to this morning, published in February. The people who keep weight off are the people who burn the most calories from exercise in the long term. So you can't stress this enough for long-term weight maintenance. And focus on healthier carbohydrates. So, you know, the low-carb crowd really annoy me. I think most of us who are not eating a plant-based diet, and I would concur with what Dr. Keneally said. If you look at the DASH diet, that was something like 60-70%. The Ornish diet and then the DASH diet are all lower, high carbohydrate, but very much complex carbohydrates. Definitely you should eliminate refined sugars. Most particularly, don't drink your sugar. Even in alcohol, which is my weak point. I'm Irish, I can't help myself, those genes run deep. I married a Frenchman too, so it's not good. And they've just published a study that says even the little tiny glass of red wine is not good for you, so it's all bad news there. decrease your saturated fats, completely concur with what other speakers have said. Increase your MUFAs, increase your omega-3s, and you can do this through vegan sources as well, of course, and there's probably a role for plant-based or Mediterranean diets. Vitamin E is used supplementally. The fish oil stuff, or algae oil in the case of if you're completely plant-based, it's tricky, right? So the data, and I didn't have time to show it all to you, shows that it helps with steatosis but not with fibrosis. But if it was me and I had fatty liver, I would take it. Again, the vitamin D stuff, it hasn't held up, at least in adults, that if you supplement them, their vitamin D levels will come up, but it doesn't make a difference to the liver disease. There is questions about whether or not we should be using it for prevention. And then the last thing I just wanted to point out, not going to show you any of the data from this, but one of the ongoing projects that I'm working on, I realized that a lot of GPs, a lot of tertiary clinics don't have any money, they don't have a nutritionist on staff, and there was a need for short, quick ways to assess diet. And we've just published the first step in a validation process, and I'm a big believer in all open access. So if you're interested in our lifestyle, our patient information leaflet, it's free, it's online. I did look at the top 10 tips, and we do say everything is really increase plant-based, increase legumes, increase everything else. We do make a comment about oily fish that I might go back and change and say you can do this with algae as well. We're just in the process, so our second step of validation has been to look at this with a nutritional intervention trial, and that work is ongoing, and we're just about to make it electronic. And so this is very much a first validation, but really working on making this accessible to everybody. So I just want to wrap up with some concluding thoughts. NAFLD is multifactorial, but there's a key role for diet. Weight loss is key, but can be very difficult. So much is good about plant-based diets, and Sue really reviewed why they're effective in more ways than just the weight loss. So the components of plant-based diets have anti-inflammatory effects. I don't really think focusing on single nutrients is very useful for public health. And then if there's any geeks out there who would like to collaborate, I just want to quickly drop in that in the lab, I work on systems biology. We do a range of both computational and laboratory stuff, and acetylation, vitamin D, sugars are all ongoing topics of interest. And I'd like to thank all the people that I've worked with in the last 10 years, and I probably don't have time for questions, but I put that up anyway.